So first of all, my apologies for the technical difficulties I had on the online study club to try to get this presentation done. And after some thought, I decided that what I would do is I would go ahead and record this out of respect for other people's time and make it available so that those that wanted to watch it could. If they struggled with some of the content, then they could rewatch it. Then perhaps we could have a question and answer session, a discussion during one of the online study clubs. And everyone that wanted to participate in that would have already had the recording of this made available, and they could have watched this beforehand and maybe jotted down their questions and thought things through. And maybe that would have been, maybe that'll prove to be a lot more meaningful to everyone. So first of all, we're going to discuss a little bit about range of motion. And a typical normal range of motion would be, let's say, somewhere around 40, maybe 45, a little bit more. But the key takeaway there is that the lateral, the right lateral and the left lateral should probably be somewhere around a fourth of the maximum opening. And if that's the case, then you have normal condylar rotation and translation. I don't bother to measure protrusive. And the reason I don't is because I'm going to be looking at that with the George gauge anyway. Now, if I'm dealing with a TMJ patient, I'm not saying I don't look at that, but for sleep, it's really not that critical. And I think the reality of it is a lot of this TMJ stuff is not very critical for treating sleep medicine anyway, because most of what we do with the mandible and the condyle and the disc complex helps TMJ problems anyway. I'm not quite sure where we get the fear that if a patient has a TMJ problem, we shouldn't be treating them with a sleep appliance, because I actually think quite the opposite. But let's delve in here a little bit and let's talk a little bit about deviation and deflection, because even though I don't measure protrusive, I do take a good look at this. So I take a look at range of motion. Then what a deviation is that's when the mandible goes from one side to the other. But first, let's define anterior disc displacement. And that's when the condyle and the disc are no longer in the proper relationship. And typically the disc is off to the anterior and the medial. But for this conversation, let's just assume it's off to the anterior. So if we have anterior disc displacement with reduction, what happens there is the mandible will deviate to the side, and they'll deviate towards the side of the derangement. The disc will relocate on the condyle, and then the patient will go ahead and deviate back towards the midline and then go ahead and open normally. If they have anterior displacement without reduction, then they will deviate towards the side of the deflection of the disc derangement, but they will not come back. Now, this patient may or may not have what you would consider a limited range of motion and opening. If it's acute, they'll be open about 24 to 25 millimeters. If it's chronic, they may be open 35 millimeters and not have any discomfort or anything, so you can get a little bit fooled with that. But if you look at lateral, a patient that is chronically closed-locked, who has stretched out all the ligaments and everything, they'll have a maximum opening around 35, but their lateral to one side or the other will be limited. And we'll touch on that here in just a moment. So deviation and deflection, those are important things, because if you have a disc problem, you're going to have troubles translating the mandible potentially, okay? Especially if the condyles have to rotate a little bit in order to cause the reduction. And all you're doing is translating the condyles, which is what happens when you put a sleep appliance in. Then you may have a little more troubles than expected, and it's good to know that going in. So I'm going to have you take your hands, and I'm going to have a hold them up like this. Keep in mind that I'm probably looking at right and left being mixed up here on this image. But let's say that the right condyle here has a displaced disc. So upon opening, what would happen is the first third of opening is rotation. So the condyles would rotate. That path of opening would be straight. Then as you begin to translate, which is the last 2/3 of opening, the left condyle would translate, but the right one would not, because there's a disc in the way. Then once the right condyle reduced itself, the disc reduced itself, then the path would come back to normal and the patient will go ahead and translate and open normally. So in an anterior displaced disc without reduction, again, say the right joint, what would happen there is the patient would begin to open, they would rotate, path of opening pretty normal. Then when the condyles begin to translate, what would happen there is the mandible would continue to deflect towards the right joint because that's the condyle that will not translate. So you're probably going to have to kind of mimic what I'm doing here because the image is not quite, it's not right to left, okay? But the takeaway there is that upon opening, the mandible will deviate towards the side of the derangement. We're going to look at that a little bit closer here. So again, a normal range of motion is approximately 3 fingers, 40 to 45 millimeters. Get up to 60, you know, that's a hypermobile joint. Not going to affect sleep appliance very much, but by definition, it is kind of a hypermobile joint. And then keep in mind that lateral should be approximately a fourth of opening. So if you got 40, 10, and 10, you can put a sleep appliance in and know that you can translate the mandible. It doesn't mean that you can't if you don't have that range of motion, but it's kind of a little bit of comfort knowing that you can. So keep in mind, like I've already said, upon opening, we deviate towards the side of the derangement. So in lateral, if we are limited in right lateral, that is left internal derangement. If we're limited in left lateral, that is right internal derangement. So let's take a look at that a moment here. Again, let's say that the condyle here, the right condyle, has an anterior displaced disc. Okay, so when I begin to move towards the right, I can have a normal range of motion to the right because the left condyle will translate. On the other side of the coin, if I take and try to move to the left, I can't move to the left because the right condyle will not translate because the disc won't reduce itself, okay? So again, in opening, we deviate towards the side of the derangement. In lateral, we are limited to the opposite side of where the derangement is. So here's kind of a takeaway too. Sometimes you'll have a patient that has a limited opening, and you might kind of think in terms of them having internal derangement with the joint, but you look at lateral and it's 10 and 10. And I'm not saying that's a magic number. It could be 8, you know, it could be 12, but let's just say 10 and 10. But they can only open, say, 30 millimeters. Then typically that is not a joint problem. It's a muscle problem. Okay, so you take a sleep appliance, do something, a design on the sleep appliance that is going to help a muscle problem, you are probably going to be okay with making the patient a sleep appliance and not having a lot of difficulties with it. So you might have to look through that. I know I did when I was first learning this. I had to rethink this over and over again before it became instinctive for me when I look at a patient to know how that was going to affect the design of what I was doing. So remember, the first opening involves rotation and translation. A mandibular advancement device is mostly translation, okay? So all we're doing there is pulling the condyles forward when we titrate our sleep appliance. So we're going to consider joints here a little bit and get some anatomy behind us and some function. This would be a normal temporomandibular joint. It's a ball and socket type joint. Obviously the socket, the glenoid fossa, is the base of the skull, as you all know. It's a biconcave disc with posterior ligament attachments. If we look at the joint under function, you will see here that this is rotation. Now, translation. Here is the posterior ligament, the superior joint space, and the inferior joint space. Now the teeth are back together. The disc and condyle and glenoid fossa are all in harmony there. So let's stop this video here a moment. So let's say that this would be more titration than you probably would have, But let's say that we pull the condyle forward, we're pulling the mandible forward to treat this sleep problem that we have. And it's not quite this simple because this is a cadaver specimen and there'd be synovial fluid and everything in here. But there is some space back here. Matter of fact, we used to go to the, before we had MRIs, I would go to the hospital and we would inject a dye in this lower compartment. And then we would essentially light the patient up with the fluoroscope and see if the dye got into the superior compartment, so we could tell if there was a perforation in the disc. Obviously, we don't do that anymore. But my point in stopping this is, let's say you've held the mandible forward for 6-7 hours when the patient's sleeping. They wake up and bring the teeth together. So when they bring the teeth together, that's going to put pressure on these fluids that have collected back here. Let's say that they even take the sleep appliance out, put their AM aligner in and force the mandible back, okay? Then obviously what's going to happen there, if there's fluid collected here or an inflammatory process going on in the posterior joint space, you're going to have a patient that is causing themselves some discomfort, okay? That's why it's what I do and many others do. This is not my invention. We wait, 10, 15 minutes, tell the patient to wait 10 or 15 minutes before they put the AM aligner in, maybe have a cup of coffee, take a shower, do whatever they need to do. Another, I think, a pretty good rule of thumb is if the patient does have some troubles, keep in mind, if you let them bring their teeth together, that by definition is going to retrude and move the condyle superiorly, which is going to press on this fluid retention back here. So you can take the patient, have them chew some gum, maybe have some breakfast or whatever. And now their teeth aren't quite coming together, okay, because they have a bolus of food or some gum or something in there. But you're kind of functioning in this area here and pumping the fluids out. Then when they put the AM aligner in, it's probably going to be a less uncomfortable for them. It's such an individualized thing from patient to patient, so you just got to kind of feel your way on that. So we're going to look at some rearranged joints. This is some stuff from Jamison Spencer. Actually, the cadaver specimens are Dr. Westenson and Erickson. Everybody's probably seen those. What we have there on the left side, this is the normal functioning joint that I showed you. So rotation, translation, disc stays right on top, posterior ligament, superior, inferior joint space. If we go to the next one now, this is an anterior displaced disc that reduces itself. So it pops off when the teeth come together. Rotation, translation, it pops back up on top and pops back off. So this patient would have a deviation to a deflection to one side, and then that would come back upon opening if you looked at the path of opening. But they would have a pretty normal range of motion. By the way, 80% of pain that is identified in the joint is coming from muscles anyway. Very seldom when we have a disc problem back here, is the pain coming from the disc itself. I'm not saying never, but it's not that common. So if we look at the next photograph here, this is an anterior displaced disc without reduction. And you can see here's the disc. It gets kind of bunched up in front. The posterior ligament gets all stretched out because every time you try to open and function, open widely, it stretches that ligament, and you essentially have no chance of getting this disc reduced. If you reduce this disc, then you might look in the patient's mouth and they would have a posterior open bite, because now the condyle is not as superior as what it was in this chronic closed lock situation. And as we go to the last picture here, this is obviously a very, very degenerative joint. There's been a perforation, it's bone on bone, there's an arthritic problem in the joint. Now you may have troubles putting a sleep appliance in and translating either one of these patients with an appliance. But even if you put an appliance in this patient and you take and pull the condyle down and forward a little bit, you're going to make that joint more comfortable. Because now during parafunctional activity at night, which about a third of the population does, at least you're not going to have the bony parts rubbing on each other. So it's not, again, not quite this simple, but I'd like to say that my limitation as to whether I'm going to put an oral appliance in a patient to treat a sleep patient is pretty much going to be kind of get impressions or kind of get their teeth scanned. If I can get that done, I'm not afraid to put an appliance in. That's not to say that if I have a patient of an AHI of 6 and they fail PAP and they're comfortable, but I know they have a chronic closed lock situation, then I'm going to try to stir up the problem by trying to put an appliance in to treat an AHI of 6. But if the patient's got an AHI of 60 and they have no discomfort, or even if they do, and they fail PAP, at some point you got to make a decision. Are we going to leave the sleep apnea untreated, or are we going to take a chance and try to get it treated? And I would encourage you to not be fearful of putting an oral appliance in someone that has a TMJ problem. Also, I want to say this. I think that there's a bit of a misinformation out there in that there's a fear that if you don't understand TMJ, you shouldn't be treating sleep. And I think that's pretty much inaccurate, because we really don't cause too many TMJ problems by treating sleep. So if I can say that another way, you can get by doing sleep without knowing a lot about TMJ. And I know there's some exceptions to that, but you can't very well get by doing TMJ and ignoring sleep. Okay. So maybe that'll kind of put things in perspective for you and give you some comfort with what you're doing. Keep in mind, a lot of this is my opinion after years and years of doing this. Anything I say here doesn't mean that this is what I think you should or should be doing. I think you should do whatever works for you and your patients. We can listen to jaw joints. We can use a device, which I have, called digital sonography. I do not use this for sleep, but you can get an acoustical fingerprint of exactly what's going on in the joint. And this is why we no longer do arthrograms, no longer do MRIs to look at joints, rarely CT scans, unless we're suspecting pathology, which we have to look at, not for sleep, but we have to look at for TMJ problems. So, on one side of the coin, I've kind of said you can somewhat ignore TMJ problems if you're doing sleep. Well, that doesn't mean you can ignore pathology that are causing a TMJ problem if you're doing sleep. So you got to kind of strike that balance there. But this is a quick example here of what digital sonography.
Here we have a normal temporomandibular joint opening and closing. You'll notice that the disc is in the correct position, and as the condyle rotates and translates down the eminence, it's a very smooth, well lubricated movement that is not going to create any vibrations. When a patient has this scenario in their TM joints, the JVA trace shows no vibrations during opening and closing, and only the teeth hitting at each green peak where their teeth are coming together. Now in this scenario, we have an anterior displacement of the disc, where the disc reduces on opening and then displaces on closing. You can see how this scenario would create a vibration during open and close. Now, not only does it create a very unique waveform so we can tell exactly what's happening within the joint, but as a screening tool, it's very easy to differentiate the normal trace that we just looked at to an abnormal trace because of the presence of all the vibrations, in this case, on the right and left during opening and closing. This can be used so that the staff member can triage a case very easily.
So essentially, this is where the teeth come together on these. This is where you would pick up the vibration of tooth contact. But you can see here is a closing click. Here is an opening click, and you can just see the rhythmic opening and closing click of the condyle. You do not need this for sleep. Matter of fact, you don't particularly need it for TMJ, depending on what level you're doing it at. For me, I was doing a lot of this, and about 40% of the time, patients would have early derangement of the joint, and they wouldn't even know it. And I could tell that by this. And this was digital sonography was originally developed by a gentleman named Bernstein. And when he first developed that, he had no clue what to do with it, but he knew he could listen to a joint. And again, it's not sound, it's vibration. Okay. So it gives you an acoustical fingerprint is what it does. This essentially, for those of us doing a lot of TMJ, replaced the need for arthrograms, MRIs, CT scans, And the data, they spent about 5 years coordinating the data between MRIs and arthrograms and CT scans to this digital sonography. So we can pretty much tell what's going on in the joint just with this. So now we're gonna take a look at teeth and occlusion, and you're thinking, what does that have to do with sleep appliances? Well, it's got quite a bit to do with it, actually, especially if you're making an appliance the patient is going to occlude on. They're going to touch it, okay? So we would look at this as dentists, and we would think this is a pretty normal appearing occlusion. By occlusion, we mean how the teeth come together. You pick up a set of models and you look at them and you go, oh yeah, this looks pretty good. And it's either good naturally or orthodontically, however that patient acquired that bite. In restorative dentistry, we would like to see anterior guidance or cuspid guidance. Basically, what we want to see there is posterior disclusion. Now, in lateral excursions, we're not putting lateral forces on teeth. That's good for teeth. It's good for porcelain crowns. It's good for periodontal ligaments. It's good for bone. There's all kinds of reasons to do that, which is well beyond our discussion here at this point. As time goes on, as we all get older, if we have a nice normal dentition, as cuspids wear a little bit, we move from what's called cuspid guidance into what's called group function, which means that the back teeth begin to touch. So we've probably all seen this if you've been doing dentistry for very long. You got this upper first bicuspid. It's got a very, very large MOD silver amalgam in it, and things go well. And now you begin to look at it. You're seeing wear patterns on the inner incline of the buccal cusp of the upper bicuspid. And then years later, the patient comes in and the buccal cusp is gone, okay? That would not happen if you had posterior disclusion, unless they bite down on something to cause it. But it can happen once we move into group function, and certainly it can get a lot worse than that. So that's just a little bit on occlusion there, which we're going to apply to sleep appliances when we get there. And after decades, this can be the result. So we know that parafunctional activity affects the muscles, it affects the joints, perhaps our sleep patterns. It can also be associated with muscle pain, headaches, and perhaps indicates OSA. Notice I say perhaps because there's a lot of variability there. So we're gonna delve into a little bit here to muscles and teeth under function. And again, what we're really trying to do is understand sleep appliances, and we're gonna get to that part. So this is Dr. Glassman, and we're gonna begin to start to look at anterior midpoint stops. So let's watch this moment here.
And a little bit more, and a little bit more, and a little bit more, and squeeze. Started to go, then backed off a little bit, and that's so with those teeth together, we don't start getting anything until we reach a very specific threshold, and they take off. All right, so when I say go, I want you to bite on your back teeth and clench your back teeth together. Go, clench, 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 relax. That's better. Okay, so let's take the numbers. What did we say? The masseter is going to get reduced by 50% and the anterior temporalis by 75%. Yeah, but you have the anti in now? Want to put it in now for me? When I say go, I want you to start to clench. Go, clench, clench, relax. Go, clench, clench, relax. Look what happens to the ability to clench.
So essentially, when you have an anterior guidance, if you have a pencil between your front teeth, if you have an NTI appliance in, if you have an anterior midpoint stop on a sleep appliance, it's maybe not quite applicable to a sleep appliance because the forces do get distributed posterior. But if you have an anterior midpoint stop, you're going to reduce the masseter muscle activity by about 50%. And with the temporalis muscle being a posturing muscle, and now the mandible no longer needs to posture itself in order to accommodate this occlusion, you're going to reduce that by about 70%. And the reality of it is the muscles of mastication do not generate much force until they have a bolus of food in there, or tooth contact, or an appliance to chew on. Okay, and you can see this here. This patient with her ANTI, and she just cannot generate the same force that she could on her posterior teeth.
And a little bit more, and a little bit.
So we're going to look at this, just a bit here again, so we can understand sleep appliances. So just kind of hang with me here a moment. So I'm going to have you take and put your hands on your masseter muscles, and I'm going to have you clench on your posterior teeth very, very tightly. And you'll see that when you do that, it's very easy for the masseter muscles to bulge, okay, as they contract. This would also happen with the medial pterygoids and the other muscles of mastication, but it's easier to feel in the masseters. Now I want you to separate your teeth just barely, and I want you to flex that same muscle. And the reality is that you really can't, okay? So all muscles, all skeletal muscles function across joints. And the muscles of mastication, the masseter muscles, say for example, function across the articulation or the joint of the teeth. So we don't really think of it in those terms, but that's exactly what happens. So you can isometrically contract your bicep muscle or your tricep muscle because that joint's in place. You can't really isometrically contract your masseter muscles. There has to be a bolus of food in there, something you're biting on, or your tooth contact. So you can do electromyography studies. I'm not suggesting that you need this either. And you can tell where and which muscles are contracting first. So for example, if we look at this, we have the left temporalis muscle, a posturing muscle, that is contracting before the right masseter muscle when the patient brings their teeth together. And you can tell that this is real time, is what this is here. So this is a 10-second time window that we're looking at. And in order for this patient to bring their teeth together, they first have to posture the mandible via the proprioception that they have. They posture the mandible, and then they bite their teeth together, and the masseters fire. It's more complex than that, but that's enough for us to understand before we go on to the next concept here. So it's kind of hard to look at these EMG studies if you're just looking at squiggles and trying to measure how high they are. But we can look at numbers. So each one of these numbers is 250 samples from the muscles. And you can see here that here is where the left temporalis fires. The right masseter is pretty much not that far behind it. But if you look at the left masseter, it is. So the right masseter fires before the left masseter does. That tells us there's tooth contact first on the right side, then there is on the left, okay? Probably insignificant. Again, at this point, we're looking at a 1 second time window, okay? So this is something that our muscles of mastication and the stomatognathing system would accommodate very easily. But upon tooth contact, the right masseter fires before the left because the right teeth contact first. Okay, so just kind of remember that. So the left temporalis fires before the masseter, and the right masseter fires before the left masseter. This results in rotation of the mandible into what is an asymmetric occlusion. It's not necessarily a pathologic occlusion, okay? But muscles behave different depending on what they have to chew on, okay? This is a further example of that. This is a patient that has a tongue thrust, okay? During normal swallowing patterns, we would stabilize the mandible and the esophagus and everything by bringing our teeth together. If you doubt that, open your mouth and try to swallow. It's like impossible, okay? A person that has a tongue thrust, in order for them to stabilize the mandible, they don't have good solid tooth contact. They put their tongue in between the teeth. You have a scallop tongue, and it's much more of a conversation than we're going to have here. But you can tell that here is the digastric muscles functioning. Here is the masseters and temporalis functioning, and here is the patient under clench. So this patient clearly has a tongue thrust. They do not have solid tooth contact when they swallow. They have the tongue in between the teeth, And we verify that by the difference in forces that they can put on when they clench. Again, not very significant to sleep, but you might think in terms of leaving the posterior open in a patient that has a tongue thrust because they're in the habit of taking that tongue and placing it between their teeth. And yet sometimes we think in terms of we're going to provide posterior contact and leave the patient room to bring the tongue out the front. And I'm just kind of thinking good luck with that. So then when we begin to integrate electromyography with TEC scan, I don't know how many of you are familiar with that, but now I can tell exactly which tooth is touching. So I'm only sharing this with you as this is the background that I brought to sleep. I'm not saying you need that. I've already said you don't. But this is why I look at sleep a little bit different than I do some people. I'm not saying you have to. I'm just sharing with you what I do here. So this is an electronic wafer, if we can call it that goes in between the teeth. And now I can tell exactly which tooth touches first while I'm looking at electromyography studies at the same time. So let's look at this moment here. So this is a video of time, okay? And you can see I have the patient close. Their first tooth contact is on the right side. You can see that the right masseter is firing first. Now, actually, we're looking at this little time window here where these white lines are. And as I continue the video, we would look at all this. So not only do you have the right masseter firing first, it also fires with more intensity, which is that asymmetry of their occlusion. But more significantly here, when I have this patient, same patient, when I have them clench tight, they have no anterior tooth contact. Okay, so what we're going to be looking at here is a patient that has no anterior tooth contact. They have an anterior open bite, okay? And now I'm going to have them slide in protrusive. So when they slide in protrusive, their back teeth do not disclude. Because their back teeth do not disclude, look at all the muscle activity that occurs, all the masseter activity that occurs when they slide their lower jaw forward because their anterior teeth have no contact, okay? Actually, this patient has been orthodontically treated 3 times. They've been unable to keep the anterior open bite closed. I wasn't involved in this orthodontic situation, but I mean, hello, take a look at the muscles, see what's going on there. But the only thing I'm trying to demonstrate here is that these tooth contact back here, they're definitely touching. And this is in protrusive. So there's excessive temporalis and masseter activity from no posterior exclusion. So perhaps EMG activity would be representative of a mandibular advancement device with posterior contact and an opening in the front. So with what I've done, with my TMJ work and stuff, I kind of asked myself just this first question: why would I want a patient to bite on the back of the sleep appliance? I have troubles thinking when I would want that done. I'm not saying never, but I kind of think in different terms, which I'll get to here in a moment. So this is a different patient. Now we've done the clench. I'm having the patient slide their lower teeth forward. So now we're looking at this time window out here, this white line here. And you can see the patient definitely has anterior guidance. They have full posterior disclusion on the right side, but there's one interference here on the left. And look at the left masseter activity, okay? You can come in and remove this interference, just do an occlusal adjustment, take care of that incline, and that immediately goes away. Why? Because without posterior tooth contact, you can't generate the muscle activity, at least at the same level. So we know that parafunctional activity can damage teeth. We know that parafunctional activity can create sore and painful muscles. We know that parafunctional activity can damage joints, kind of exacerbate clicking and locking and that sort of thing. We also know that parafunctional activity can contribute to headaches, craniofacial pain, and can be related to sleep apnea. parafunctional activity can also influence our oral appliance compliance. So if you got a patient, that has some facial discomfort and some facial pain, had neck pain, headaches, they're taking pain medication over the counter daily, and you're going to put a sleep appliance in their mouth, probably going to help the joint, probably going to help the muscles. But if you give them something to bite on in the back, you might aggravate the muscles too. This is where anterior midpoint discluding stops comes in, because for me, anterior midpoint discluding stops lessen the parafunctional activity and therefore the stress on our appliances, and most likely then also improve muscle and joint comfort, and then probably also compliance of our oral appliances. Okay. Now I have nothing to base that on other than the years that I've been doing this. So there's literature out there that kind of supports this if you kind of piece it together. But for me, coming from TMJ to sleep, obviously one of my biases is to put an anterior midpoint stop on my appliances. So we're going to address something a little bit different here now, because there's some, again, I think some misinformation out there that NTI appliances can cause anterior open bites. Well, that's not misinformation, because it can, okay? And we're going to discuss that a little bit here so that we can understand how an anterior midpoint stop might or might not be an appropriate thing to do for a sleep appliance. Obviously, I happen to think it's very appropriate. That's all I do. So a sleep appliance with anterior midpoint stops, they don't seem to create anterior open bites. They can create posterior open bites, okay? So you got an NTI appliance which can definitely create anterior open bites, and I'll show you a case on that. But don't let that make you fearful of putting an anterior midpoint stop on a sleep appliance, because of the traction of the appliance, we don't see anterior open bites with anterior midpoint stops on sleep appliances. So if you're not going to use an anterior midpoint stop, that's fine, but don't avoid one because you think it's going to cause an anterior open bite, because I'm going to tell you it's not. Here's perhaps the reason. An NTI allows the mandible to go wherever it wants. There's no traction. We're not trying to pull the mandible forward. We're not holding it forward. A mandibular advancement device, with or without an anterior midpoint stop, puts a traction force on the mandible as it is pulled or pushed, depending on the appliance, forward. And this is mostly translation with very little rotation, because we really would also like the patient in the mandibular advancement device to have lip closure, therefore nasal breathing. So we try to even eliminate rotation of the mandible by elastics or lip tape or something to keep the mandible closed. And we're going to look into this a little bit more clearly here, I hope. But we're still on this anterior open bite thing, because some people think that it intrudes anterior teeth. Some people think that posterior molars erupt, and neither of those are true. So there is concern expressed by some practitioners that long-term nightly use of an NTI device will cause supra-eruption of the second molars, but curiously, not the first molars or the bicuspids, etc. This concern stems from the dynamic described in the paragraph below. This is some work from James Boyd. A potential diagnostic revelation of NTI use is the development of an anterior open bite, of which occurs as the result of the reorientation of the condyles following normalization of the musculature. He calls it the dynamics of condylar seating. This can only happen if the condyles were in a position anterior and inferior to their optimal musculoskeletal stable position. In other words, they're not in the center of the fossa. Let's just call it that the normal position. And then they reposition to a more posterior, superior position upon wearing the NTI appliance. This causes the mandible to pivot or rotate as the most posterior, superior position, as the condyles move, then the mandible rotates like this and you get an anterior open bite. So this causes the mandible to pivot and rotate at the most posterior molars, thus giving the appearance of posterior supereruption, which is not the case. You can take a set of study models, put them back together, and you realize, well, the teeth really haven't moved. And I actually did that with my first anterior open bite, shortly after which I called Dr. Boyd up and said, okay, what's going on here? That was decades ago. So as the condyles seat more posterior and superiorly, the anterior portion of the mandible simply rotates posterior and inferior, which, depending on the amount of the incisal opening or the incisal overlap, may appear as just this, or it may appear as an anterior open bite. Okay, depends on the degree of opening. So we'll see if we can clear this up just a little bit more. So the elevating forces slowly seat the condyles. So although it may take a week or months, again, this is from James Boyd, although it may take a week or months, elevating forces will slowly seat the condyle from its former position, B1, there's not a picture of that here, to its optimal position, diagram B2. As the lateral pterygoid muscle slightly stretches, okay, so there's nothing wrong with the lateral pterygoid muscle doing that. It's, as a matter of fact, it's an offender quite often in TMJ patients as it's shortened and in spasm. Once the lateral pterygoid has remodeled and allowed the condyle to then seat superiorly and posteriorly, its contraction can still only advance the condyle. That's its only motion. There is no muscle to pull the chin up, as James Boyd said, and if an anterior open bite has developed, the simple cessation or stopping the use of an enhanced deprogrammer use may not allow the reestablishment of the less than optimal condylar position. What he's saying there is the reason that mandible rotates is because the condyle is not in a good position to begin with. There's not good harmony between the occlusion, the muscles of mastication, and the joint. So as you put an anterior deprogrammer in an NTI appliance and you allow that rotation to occur, oftentimes just taking the appliance out doesn't make it go away, okay? Because the muscles and joints are happier there. And of course, you can have tongue thrusts that develop, which help maintain that as well. But to the casual observer, the posterior teeth may appear to have supererupted or the incisors may have intruded. However, there's no orthodontic studies that show posterior tooth supereruption due to lack of nocturnal alveolar stimulation. Keep in mind that that's a different statement than saying that if you take out a lower molar that the upper tooth isn't going to supererupt, because it will, okay? What he's saying here is if you wear an NTI appliance at night, you separate the posterior teeth. It's not exactly like you're going to have posterior tooth eruption because during the day you're functioning on your teeth. If nothing else, every time you swallow, it's 2,000 times a day. That is going to prevent those teeth from super erupting. If they did, it super erupt a little bit at night. So it's just a non-issue. So there's not been any studies showing that mild to moderate sporadic incisal forces can cause incisors to intrude either. So NTI appliances do not cause posterior open bites. They do cause anterior open bites, but it's from rotation of the mandible. So let's just work from that framework here if we can. So the elevating forces slowly seat the condyles. You can see that here. This condyle here is down the glenoid fossa, okay? Teeth are together. And as you put the NTI appliance in, the mandible rotates, the condyle seat, and you end up with an anterior open bite. So if the condyles do move to a more optimal musculoskeletal stable position, as shown in Dawson's text, the degree, if any, of the potential resulting anterior open bite is the degree of the superior and posterior repositioning at the initial degree of the incisal overlap. For example, in a class 3, edge to edge, slight condylar seating may prevent the incisors from touching, and you would notice an anterior open bite. Anyway, you get the point of what I'm saying there. Okay. So this is an 18-year-old. Again, we're going to get to sleep appliances, but I'm going to give you this background first. This is an 18-year-old that came to me on narcotics. She was on a contract with a pain doc, got 8 or 9 pills a month, and had been on that for quite some time. I forgot how she found me, but we put an NTI appliance in. Within 7 days, I had her off the meds. I had a discussion with the patient and mom that occasionally, 2 to 5% of the time, we'll get anterior open bites with NTI appliances. And of course, the discussion we're having is, okay, drugs or open bite in an 18-year-old, what would you rather have? Well, for my daughter, I'd rather deal with an anterior open bite, okay, and get her off the drugs. I can't imagine where an 18-year-old gets at 30 years old and 40 years old when they've been on meds to manage the discomfort they're having, okay? So, I had buy-in from mom and the patient, and now, lo and behold, here we are 9.5 months later. I don't really bother to take pre-delivery of NTI plants pictures. I should probably, but I've just done this so long that it just happens sometimes, and I accept that. So here we are 9.5 months later, and we have an anterior open bite. Keep in mind, this patient has not been on meds for 9.5 months, okay? Trust me, I got buy-in from this 18-year-old, okay? I certainly have buy-in from mom. So we take her out of the appliance, okay? And what we want to do is see, okay, we take you out of the appliance and we want to strike a balance. Do you have to go back on meds? So my arrangement with her was this. You go out of the appliance, you stay out of the appliance until you feel like you have discomfort that was of the status that made you get on meds to begin with. When that happens, you put the NTI appliance back in. And let's see if we can get some of this to return to, quote, what was your normal again. And if we can, we can. If we can't, we don't. Okay, but we'll see if we can do that. So here I am. Oh, I want you to notice in this here, the midlines are lined up. Okay, tongue's kind of coming into play here now, but the midlines are lined up. So I take the appliance away this day. Here we are now a month later. Midlines are not lined up so much. Teeth are starting to touch a little back here. We have a little bit of incisor overlap. Okay, cuspids are starting to come into contact here. Still missing this a little bit. I'm not saying the occlusion is great. Okay, but the mandible is shifting this direction. Okay, we have a crossbite. Actually, what we have here is we have a narrow maxilla compared to the mandible. It is not a bilateral crossbite. This is what we call a unilateral functional crossbite. So the patient shifts their jaw one way or the other in order to get some sort of intercuspation or functioning of their teeth. So we have a midline. We now have a midline shift to the right, a functional crossbite that produces retrusion of the right condyle and translation of the left condyle. So for example, that mandible is going to shift this direction. This has to happen, okay, with the condyles. So everything's still comfortable. The patient's doing good, hasn't decided that at a month that they're even having any symptoms at all. So we're thinking, oh, we look like we're closing the anterior bite down. Here we are 2 months now. It's closed down even further, and the midline shift becomes even a little bit more evident, okay? So essentially what was going on here is the mandible was coming back to where there was more of a synergistic balance between the muscles and the joints and everything. The occlusion wouldn't allow that, okay? Here we are a year later, okay? Midlines are not lined up. We have more of a solid occlusion back here now. Teeth haven't super erupted. The mandible's unrotated, if we can call it that. But the patient with intermittent wear of the NTI appliance is able to stay off meds without suffering, because that was a rule I kind of laid out for him. I says, it's not like I want you to go out of the NTI appliance and then if you have pain, put up with it for a month and a half before you put it back in. I says, if you begin to feel like there's discomfort, you put the NTI appliance back in, and we'll see if we can strike a balance between that anterior open bite staying closed and staying off the meds. And she's been very successful with that. I'm not saying that would happen in every patient. So if you were going to surgically do something with this patient, which I would not suggest because we've been able to manage this in other ways, you'd have to probably go ahead and do some orthodontics, maybe split the palate, get a wider maxilla so you can accommodate the mandible. I certainly wouldn't take out bicuspids to do that. This is a whole different conversation. but essentially you have a mandible and maxillary discrepancy here, and the muscles don't like it very much. And we found a way for the patient to maintain this. So anterior midpoint stops. Having dealt with TMJ patients for over 4 decades, it's very natural for me, it became very natural for me to place an anterior midpoint stop on all of my sleep appliances, not some, all. For me, it is easier to have that fabricated at the lab, not need it, and then remove it if I need to, which I've never had to do, than it is to need it and then have to add it later, especially with milled appliances, because you got this nice fabricated appliance. Now you mix up some acrylic in the lab, you kind of glob that onto the front, and it looks like they don't belong together. I'd rather have that fabricated in the lab and grind it off, again, which I don't have to do, but grind it off than I would add the anterior midpoint stop later. So as Barry Glassman, I said, I'm kind of paraphrasing this, so these aren't exactly his words. I recall him saying something like this. So when he was asked, when do you order an appliance with posterior contact? And he says, well, whenever I want to give the patient something to clench on. And, well, you know, why would you do that? Okay. So in the rare instances for me, where posterior contact is needed, which is typically for me, not with a muscle problem, okay? But if I have internal derangement of the sort that needs some posterior support, I wouldn't grind the bump off, reduce the vertical, okay? Although I don't know how vertical plays into sleep appliances, but for TMJ, I would want that joint supported. So what I would do is, in those rare instances where I felt I needed posterior contact, I would simply adjust the bump to the height I wanted it, which is usually I'm not reducing it, but I could. But you know, you talk about guesswork, who knows how you should do that? I'm not into pharyngometers and all kinds of that other stuff. I'm not critical of those that do that. It's just not what I do. But then I would add a pad of acrylic to the posterior on both sides and have the patient ever so slightly glide around on the bump on the anterior midpoint excluder while the acrylic was soft. So now as those condyles are, you know, coming down the glenoid fossils and that mandible is arcing back and forth, I'm exaggerating here, as the mandible is doing that in the posterior on that soft acrylic, now I'm establishing a functional, okay, occlusion, if you will, on those posterior pads, having them sliding protrusive too. And what I end up with then is a good functional posterior bilateral tripoded platform that is functionally balanced 3-dimensionally. So I'd rather add posterior contact than I would an anterior discluding element. So have you ever had this happen where you have this perfectly balanced appliance, you think, at delivery, and it's no longer balanced after 6 weeks of titration? So you're in there kind of grinding on the side of it, or they have muscle problems on one side or whatever. So generally, if that happens, it's the asymmetrical translation of the condyles, or it can be due to a disc condyle issue, or asymmetrical condylar inclinations. So I simply prefer to avoid those situations because I don't have to add posterior acrylic support very often, like almost never. I don't have evidence of this. I don't own a matrix, but I have heard people say this, that the compliance for patients that have their appliance designed with a matrix, again, I'm not experienced at this, that the compliance of wearing that appliance is a little bit, is better. I don't know if that's because you've reached a more therapeutic sleep position sooner, or if you've captured the bite registration closer to the therapeutic position and you're only tweaking it, you know, 0.5 millimeter one way or the other to get the SpO2 values to come into play, to get them where you want them. So essentially what happens there now is you've taken that bite registration closer to the therapeutic sleep position. So now all this condylar stuff has already played out in your bite registration, instead of fabricating an appliance at a position that you think is correct, and you've got all this condylar stuff and disc stuff and muscle stuff program into that fabricated position, but then when you titrate it, that becomes a different animal. Let me explain it this way. So let's say you put a patient where the condyles want to translate asymmetrically, let's say because one of them has an anterior displaced disc, and you put them in a TAP appliance, okay? And I like TAP appliances, okay? My bias is TAPS and Herbst, which I'll go into in a moment. But let's say you put that patient in a TAP appliance. And let's say that you take the bite registration where the condyles have rotated a little bit, and actually not really how that occurs, because when you take a bite registration with an open bite registration, whether it's for a night guard or whatever, or you take an open bite registration for a sleep appliance, that is mostly just taking the mandible, instead of opening it like this, you're opening it like this, okay? But when you take take that bite registration and then you continue to titrate the mandible, so then what happens is those condyles may not want to translate symmetrically, but a TAP wants to make them translate symmetrically, okay? So you may take a fabricated position where you took the bite registration, say for a TAP, and then you may take and put the patient in a TAP, you begin to titrate it, and now it becomes a problem with the joint, okay? It can also be a problem with the muscles, but in a TAP appliance, you would simply have, especially if you've ordered it without posterior pads, you essentially have an NTI appliance in. You just don't have a mandible that can adjust either way. Let me explain that a little differently. On one of the study clubs, Guy had mentioned that he had a Sereno appliance and that he really liked that, found it very comfortable. Then he said this, he says, but I did have it fabricated at my therapeutic position that my other appliances are in. So now when he sent in the bite registration for the Sereno appliance, which has those blocks on those posterior blocks on the appliance, he really didn't have to titrate that appliance because a therapeutic position for that particular appliance was built into it. So I like a Sereno appliance. I just wonder how much more problems you're going to have with that potentially compared to an appliance that has an anterior midpoint stop where all those variables have been taken away. So I'm not saying you ought to do things one way or the other. I'm just giving you the rationale behind what I do. I will say this, and this is a bit anecdotal. I've noticed that it took me a while to notice this because I've done a lot of NTI appliances. So I've experienced a fair amount of anterior open bites. But it seems to be the patients that have those kind of anterior open bites, and we've all seen these patients, they have posterior cusp wear. And you look at the anterior teeth, and there's really very little wear on the anterior teeth, even on the linguals of them, the linguals of the cuspids, or the buccals of the lower cuspids. There's very little evidence of wear on the anterior teeth, but the posterior cusps are kind of worn down, even to the dentin. I'm not sure what that means, other than maybe that's the condyles trying to do this, and the teeth are kind of the victims in the way. But I have noticed that of the patients, once I began noticing this, I have noticed that many of the patients that have developed anterior open bites with an NTI, not with a sleep appliance, but with an NTI, they have had this molar wear configuration. So keep in mind that a mandibular advancement device fabricated with an anterior midpoint stop, even in a patient whose condyles are both anterior and inferior, is not going to allow, the sleep appliance is not going to allow the condyles to go posterior and superior, which is what causes the anterior open bites of the NTI appliance to begin with. And I've already kind of alluded on this. It's because of the traction or the titration that we do with a sleep appliance, which is totally different than an NTI appliance. So without the condyles being able to go posterior, okay, so the sleep appliance won't let the condyles go posterior, well then they can't really go superior either and let it rotate, because you got a glenoid fossa and a disc, even if it's anterior displaced, you just got things in the way, okay? So I think that a valid statement here is whether you have a sleep appliance with an anterior midpoint stop on it or not, I think it would be valid to say that don't worry about an anterior open bite, but either of those configurations, in other words, either a sleep appliance with or without an anterior midpoint discluding stop, you can develop posterior open bites and also posterior contact problems between the molars. I mean, those are all, I think, products of the sleep appliance, which have nothing to do with the anterior midpoint stop. So this is something that I hope is of value to you too. An NTI, you know, when we call it an anterior midpoint discluder, it's narrow and a little longer. Sleep appliance manufacturers, they seem to want to make these broad, okay? They're more of a platform than a midpoint stop. I continually have to get them to make these narrower. I'm not sure that's significant or not in a sleep appliance, to tell you the truth. But I want them, I mean, we call it an anterior midpoint stop, not an anterior midpoint platform. This happens to be not my appliance, but it's an appliance that another dentist had contacted me about. Took them 2 hours to deliver this, which is a totally different type problem. But when we look at the anterior discluder that they built on this, you can see it's not out very far, which it doesn't have to be. What this appliance had to go back to the lab for a variety of reasons. But I didn't get a chance to look at the lower component to this. But if that lower platform is not wide enough anterior posteriorly, which it might be, you will have the risk of that patient protruding the mandible on their own, not during titration, and then falling off the front of the bump. So you don't want that to happen. You don't want the patient to be able to do that, okay? So you can either make the bump longer this way, anteriorly. You don't have to worry about lingual because the appliance is going to prevent it from going back. Or you can make the platform, if you can call it that, on the lower longer. I don't really know about this appliance, but in that particular scheme of things. But if you're going to put anterior midpoint stops on appliances, you got to kind of look at that too. So this is something that I do. I'm not saying you have to, but I think you'll understand the rationale behind why I do this with what I've already explained. I always use a 2mm bite fork, okay? Not for any other reason other than I don't want to have to make a determination how much room am I going to need to put this appliance in, and then I get too much, and then the lab makes a big, thick appliance, and then I've opened the patient up with more vertical than I actually need to. So I take my models, I do pour them, have staff pour them. I put the bite registration in and I mount it up on a plasterless articulator, the Galletti articulator. I set this stop back here. Then I take the bite registration out and I look and get an idea of how much room do I have here? How much clearance do I have here? I don't measure it. I don't make little acrylic things that I can put back in the back that because the curve of Spies vary, the curve of Wilson varies. And there's so many variables here. The condyle inclinations vary. I just choose not to try to guess at that, okay? So I'm not saying I ignore it, I just compensate for it in different ways, okay? So let's call this an anterior open bite, okay? An anterior open bite registration. In other words, we put a George gauge in and we've done this, okay? We haven't done this. So you see there's approximately the same amount of space in the back as there is in the front, okay? This is where the bite rate, this is a stop on the articulator, so I know this is where the bite registration was. So then I simply tell the lab, I say, so I want you to make the framework as thin as you possibly can for strength. It's a milled material, so it doesn't need to be very strong. Another one of my biases is thermocryl for a variety of reasons. I'm under control of my patient's dental work, other dentists are. I don't want to have to remake an appliance, and the patient doesn't want to have to have one remade either. So then I ask the lab, I say, so you make the appliance as thick as you need to make it, and you have the freedom to go ahead and minimally open up the bite registration and to accommodate the appliance. And it took me a while to get that accomplished because they were concerned about the appliance being strong and all that kind of stuff. And finally, I just had to say to my lab, look, please just, do as I've asked for you here. And if the appliance breaks, I'll pay for it. I've never had one break. Okay. Well, part of that's because I'm not going to reduce the bump and let the patient bite on the back of it. If I need to add posterior support, I'm going to add acrylic to it, which is going to thicken the appliance. It's not going to, it's not going to make it thinner. And surely they can make it thin enough to where I'm not going to have to adjust on the back of it at delivery, although we do have to watch them. So then I get the appliance back from the lab. I take and remount the models on the articulator with the bite registration. Then I put the appliance on the articulator. This takes about 3 minutes. Okay. So I'm loading a little time into the front, but I'm predicting delivery. So then I look at how much did they open the appliance, the models up, and it's approximately this much. So, I've never delivered one of these, and the patient says, this feels like it's open more than it was at the bite registration. I mean, nobody's ever said that to me. Okay. No patient has ever said to me, this is open too far. Okay. And don't get me wrong, I try to minimize that, but I try to also let the lab do what they need to do so they're happy with what they accomplish, and I simply protect the whole thing with an anterior midpoint stop. This is a picture of the appliance. You can see the anterior midpoint stop here and no posterior contact. These pictures were a little hard to take, but you can get an idea here. Now you will notice here that unlike the anterior or the open bite registration, where we do this, you do get the illusion, fact, that this is thinner, less space available in the back than the front. That's because I've asked the lab to go ahead and open the vertical up a bit, and they do that on an articulator. They don't do it this way, they do it this way. So this is not by design, but I think it would be fair to say that because of that, all of my appliances do have some rotation of the condyle built into the appliance. Is it significant? Probably not. Okay. Do I do that is that the purpose of me doing it this way? No. Okay. I just want a thin appliance and an anterior midpoint stop. And I know I'm going to use thermocurl, so I'm going to have two materials in there to begin with. But I am checking the appliance clearance on the articulator. So at delivery, I predictably know, am I going to have to adjust this or not? And did I get the lab to do what I needed them to do? So also keep in mind this minimal clearance I might look like I have back here. At titration, as the condyles continue down the glenoid fossa, I'm going to get even more clearance, okay, in the back. And that's as the condyles descend. This is this particular case here is a TMJ patient. She's wearing CPAP. She came to me for an oral appliance, had been off her CPAP for 2 months. I got her back on her CPAP. She's wearing that. And then she reached back out to me. She wanted to replace her night guard now, which she was wearing without her CPAP, which is a whole different conversation. She wanted now a sleep appliance. So you can see here that I had it fabricated, a millimeter opening of the screws at fabrication. This is mounted on the Galletti articulator. The reason I remount these is I have had the lab before take and fabricate the appliance, attach the hardware, then open the screws. And it's very critical that I'm able to retrude this lower element of the sleep appliance if I need to in this patient. I doubt I will, because I took a very, very conservative bite registration on it, knowing that I'm probably not going to, first of all, she's probably not going to tolerate it very well. But second of all, I'm not going to need to titrate it very much because I'm just stabilizing the mandible to make it more effective for her CPAP. So we're kind of maintaining the airway and then relying on the CPAP to keep it open. So this kind of demonstrates how condylar rotation will actually create more opening in the front than the back, okay? So what I did, this is the same case. What I did here is I took the articulator at the bite registration and I simply opened it up in the front another 3 millimeters, and you can see how it opened more in the front than the back. Okay. And so again, you don't need mud clearance in the back. That's going to get better. So I wanted to make this presentation available rather than try to do it on the study club, end up with connection problems. Then I haven't really been able to orchestrate this for you in any sort of organized manner. In this way, hopefully I can make the video available. You can choose to watch the video or not. If you do, and there's parts of it that don't make sense, you can rewatch it. If there's parts of it that you don't agree with or you have questions about, that's free game. Then we can actually have a question and answer period on the online study club and save ourselves the time and everybody else of having to go through the videos should they choose not to. So I would encourage you to ask anything or disagree with me or not change what you're doing if it's working for you. But this is why I do things the way I do. And it's my background in TMJ that led me to this path. I'm obviously, my bias is thermocrel, thermoplastic material. My appliances fit first time, every time. Dental changes, 30 minutes, it fits again, okay? And my second bias is either a tap or a Herbst, not so much from appliance designs, but that's the two that I can get thermocrel in easier. And it just so happens that I can make both those appliances fit my requirements of having an anterior midpoint stop. So I hope in some way this helps and that it stimulates an interesting conversation.